Hello and welcome to the third Dementia Researcher Salon debate. I'm Adam Smith, I'm the Programme Director for Dementia Researcher, and I'll be your host for the next hour. Thank you for joining us here in the Dementia Researcher community. Today's motion addresses yet another complex issue. This House would make genetic testing for dementia risk available to everyone aged over 40. As interest in personalised medicine grows, so too does access to genetic risk profiling. Companies like 23andMe, Ancestry and Gene Health offer these services already. So would universal testing empower people through knowledge and early detection, or does it bring ethical, psychological and practical challenge that means we shouldn't really be doing it? Speaking for the motion, we have Dr. Oscar Lazo, who's a research fellow in the UK DRI at University College London. His work explores how RAB10, small GTPase, regulates endosomal plasticity to identify new therapeutic targets against dementia, particularly in the context of Down syndrome. Is that right, Oscar? It is? Perfect. Speaking against the motion, we're joined by Professor Terry Quinn, the David Cargill Chair of Geriatric Medicine at the University of Glasgow. His research focuses on stroke, cognition and trial methodology. He leads the Scottish Brain Health ARC, sits on the national and international guidance review boards, and works to ensure research informs both clinical practice and policy. Is that good for you, Terry? Close enough. Thank you very much, both of you, for being here. Let me explain the format to you. So here's how today's debate will run. Each speaker will begin with 10-minute opening statements to present their case. We'll then move on to 15 minutes of exchange and rebuttal, where I will invite each of them to respond to each other's comments. And after that, we'll open the floor for 15 minutes of audience questions. In fact, you can ask your questions at any time. You don't have to wait. And I've enabled the Q&A in the chat now. And then finally, each speaker will give closing remarks and we'll end with a final audience vote. But to begin with, we're going to begin with an audience vote where we're going to invite all of you to tell us where you stand at the start of this discussion, the start of this debate rather, on this issue. So I'm going to share my screen now. Posted in the chat there is a link to our Slido where you can vote now. We're going to leave voting open for a couple of minutes. We did send out the voting link with the email event reminder about an hour ago. So let's jump across and share my screen so you can see where we currently stand. So a reminder of the motion for this evening. This House would make genetic testing for dementia risk available to everybody aged over 40. And so far, the votes are coming in. Do click that link. I know that if you're watching in the app, annoyingly, that's going to jump you off to your web browser briefly so you can do that vote. But it literally just takes 2 seconds and then swipe up and across and come back and you should be able to get straight back in. So looking at the vote as it stands, so far we have 67% of the audience agreeing with the motion and are in favour of genetic testing for over 40s. 15%, apologies for the typo there, 15% disagreeing with the WHO. Who could we disagree with the WHO? And 13% of you undecided. So, Terry, it looks like you might have your work cut out in persuading our audience, but that's good. You've got room to maneuver. But today I'm going to leave voting open for just a minute more. But Oscar is going to go first. I'm not going to leave that open for too much longer after Oscar talks, but I'm going to hand over to Oscar now. And for the first time in 3 weeks, I'm going to remember to set a timer because I think I've been forgetting to do this and then sitting here nervously thinking, has somebody spoken longer than the other? So, Oscar, I'm going to hand over to you now. I'm going to stop sharing my screen. Do keep voting if you haven't already. Do post your questions for Oscar and Terry in the chat. And Oscar, I'm going to hand over to you. Please make the case for why the genetic testing should be offered for over 40s.
Thank you very much, Adam. And it's a great pleasure to be here debating with Terry as well. And we're gonna keep this, nice um, and inspirational for you people to have this debate too at home or in the lab or in the whatever the setting you work at the moment. And I would like to start saying that when I say that this house would make genetic testing for dementia risk available to everyone over 40, you obviously immediately think that there is something that I know that you're expecting me to say, just because it's such an obvious thing to say. Knowledge is power. You know, the more you know about yourself and the environmental and intrinsic risks you face, the more informed your decisions are going to be. And in the case of dementia diagnosis and genetic testing, we can provide interesting evidence of that. But in my opinion, individual benefits are not the key of this debate. Um, I think too often we frame biomedical debates only as a fair balance between risks versus benefits at the individual level, with the bioethical framework of doctors and patients relationship, which is the typical way we think about this. But more and more, I think we need to include the communitary dimension. Vaccination, for example, is not about your risk only. It's about herd immunity and protecting vulnerable individuals um, in the community. When you think about climate change impact in public health, it's the same thing. It's not only about the economy of your country versus the risk of your population. It's also about damage imposed to poor countries on the other side of the world. It's about future generations, people don't even exist yet. What I'm trying to say is that offering genetic testing to everyone over 40, this is years before people showing clinical symptoms, is not only important as a strategy to manage environmental exposures at the individual level, which is already attractive, but also a source of really important public goods. One of the most amazing features of the NHS, I hope you agree with this, but this is certainly one aspect that is the envy of most of the world, is that every point of contact with patients is a potential research and innovation opportunity. Offering genetic testing for something as prevalent as dementia, I don't need to remind you that, one of every three people over 85 or 90, it's at risk. Offering that has the potential to produce an immense amount of clinical data correlating genetic variants, exposures, and age of onset of different types of dementia, which is precisely the type of data we need to advance towards better personalized medicine and to have a better understanding of protective factors, disease trajectories, and also potential candidates for clinical trials. It can help to identify populations within the perfect time frame for preventive treatments as well, which is where most of the hope is right now in prevention. The value of this data is obviously monumental, and perhaps Professor Quinn will say that the costs are massively big too. But sometimes big missions create great public value too. So, and I want to go, I hope not too far, but there is a beautiful example on the missions to put the first humans in the moon, which made the US to create NASA and exponentially increase their critical mass on aerospatial scientists. Because obviously flying to the moon was terribly expensive and quite useless, if you like. But they needed to build, to be able to do that, you need to build big facilities, launching sites, massive launching sites, employ thousands of people in the technology industry, develop, let's say, new engines, new sensors, new materials, new software. So the pull on the industry of knowledge and science of all kinds was of literally astronomic dimensions. The opportunities for innovation produced um, a massive, what I think is a massively positive economic impact, far beyond the costs of this enterprise. And obviously, this is not something I came up with. These are the ideas of one of our most prominent innovation economists, Professor Mariana Mazzucato from UCL, and her concept of mission economy that can make economic systems to align towards big priorities of a country or of a society, and develop innovation, technology, and public infrastructure, which impact will go far beyond the mission itself. It's not only about genetic testing in the end. Uh, can you imagine the pull on biomedical research, on genetic testing technologies becoming much cheaper, much accessible, the knowledge intensive jobs creation that this will trigger because of the scale of the thing. Of course, individual immediate benefits also matter. And there is a recent pilot study in the Netherlands last month, actually it was a couple of days ago, suggesting that genetic testing could change and help the diagnosis of more than half of the patients. And this was in a public health setting. And you can effectively identify both, which is important, causal pathogenic variants, also rare risk variants, and also build up polygenic risk scores that in the case of that paper will predict more or less a 7-fold increase in the probability of dementia diagnosis for that specific population. And I think this alone would be a very good reason to ask for a genetic test yourself right now. And this, of course, needs to be done in a way that protects autonomy of the people to whom this test would be offered, providing counseling and having a strict governance of data to comply with our own standards in the UK, I think. And I think there are already clear rules for something like that, and it can become an important tool for decision making at a crucial point in life. But I guess we also have to start thinking beyond that, beyond the individual impact of this, and recognizing that knowledge is power, but also at the social level. And this is where this research-enabled risk stratification offer, which is what I think is, could build up capacity, would create our opportunities to come up with effective treatments and become a mission to help creating what I would like to say is, or maybe, a memorable future.
Oscar, you only used 7 minutes of your 10. So well done. But thank you very much. I'm not going to comment at this stage. Instead, I'm going to hand directly over to Professor Quinn, who is now going to speak against the House. And over to you, Terry.
Thanks, Adam. And I have to say, Oscar, I'm convinced already by your argument, so this is going to be difficult for me. So I guess to make the argument against offering genetic screening for everyone aged over 40, I've got three main arguments that I want to make. And to put the first argument in context, I'm going to share with you, Adam and Oscar, because we're all friends, a shocking truth. I am aged over 40. Don't act too shocked. And don't confuse my chronological age with any kind of maturity, because I'm not mature at all. I also have a very strong family history of Alzheimer's disease. So I'm exactly the kind of person that this argument, is very real to. And as I was reflecting on the argument, I really thought when I was younger, I would have been 100% on your side, Oscar. I'd have said, knowledge is power, bring it on, I want to know this stuff. But for me now, the stakes are very different. And this is my first argument. Because right now, if I have a genetic risk of Alzheimer's, amyloid is starting to form in my brain. Tau is starting to phosphorylate in my brain probably right now. And if I have a genetic test that tells me I'm high risk, what does that mean for me? What does that mean for my insurance? Do I tell them? Is my premium going to go up? Will I be able to afford that? What does that mean for driving? Will I have to tell DVLA? Will I have to have a driving test every few years? Believe it or not, I'm in a job where I have to make important decisions every day. What does that genetic knowledge mean for that job? Will I have to tell my employer, the NHS? Will there be scrutiny of all the decisions that I make? And will I be scrutinising those decisions with that knowledge? Will I have confidence in my own cognitive ability if I know that I'm at risk? And what does it mean for my kids and my family? So unfortunately, my kids are seeing firsthand the devastating effect of dementia because it's affecting my father right now. They know what that means. How will they react if they know that dad is very likely to go the same way? I'm not sure, but I think it could be quite difficult for them. And there's a problem here because once you know, you can't unknow your genetic risk. And I think people just need to think in their head, what does it really mean to know this? There was an interesting article in the BBC News a couple of days ago about some real horror stories related to companies like 23andMe, where people had got genetic testing and actually it ripped their family apart because it turned out their parents weren't who they thought their parents were, things like that. So genetic knowledge is power, but it's power that can actually be quite dangerous. And I just don't think that society is ready yet, for all of those reasons that I've put out there. I don't think society is ready yet to really make use of the information that we might get from genetic testing. So that's my argument number one. My argument number two is around accuracy, and I want to put that in a context by telling a story that one of my colleagues told me. And I'm actually not sure if this is a true story or not, but it's a good story, so I'm going to share it. He was looking after a patient who he thought may have a monogenic form of stroke disease that would have meant the person would have been really in a care home by middle age. Did genetic testing, and it turned out the person didn't have the mutations. And that evening, my colleague was on call for medicine and saw that patient in the A&E and said, well, what are you doing here? And after coming out of clinic, he went to the pub, had a couple of drinks, and then he got hit by a bus. Why am I telling you this? I'm telling you this because genetic risk doesn't completely predict your future. Life gets in the way of genetic risk. And actually, for diseases that are diseases of older age, like dementia, you have a long life that can start to interfere with that genetic risk a little bit. And if we try and put that into numbers, I've had the absolute privilege of working with some of the UK experts on things like genetic risk, ApoE, polygenic risk scores. And even for the best polygenic risk scores in some of the projects that I've been involved with, their prognostic accuracy is sitting around 70%. Now, at a population level, that's really good. For informing public policy, for thinking about planning, really good, no doubt. But for the individual person, 70% prognostic accuracy isn't actually that good at all. That's like 2 bullets in a 6-barrel gun and playing Russian roulette. A 1 in 3 chance it's going to be wrong. And it's wrong for exactly those reasons that I outlined in that little story. The expression of the genotype is very much influenced by the life course and all of the exposures along the life course. It's dark now, so you can't see outside my window, but if you could see outside my window, you'd see the East End of Glasgow. There are areas in the East End of Glasgow where male life expectancy sits around 60. Now, that's not just genetic code, that's postcode. And so that's why this genetic risk doesn't tell us the whole story. All of these other things happen to interfere. And then the last thing I want to talk about, Oscar, you used the phrase and Adam used the phrase, knowledge is power. And I agree, knowledge is power. This is really, really powerful. But it's only beneficial power if you can use it in a beneficial way. And I wonder, if I was told I was high genetic risk for Alzheimer's, what would I actually do with that information? Right now, there aren't any treatments. Now, you may say there are disease-modifying drugs, and there are, no doubt. And you may say, if you give those disease-modifying drugs at middle age, you can halt the phosphorylation of tau and the beta-pleating of amyloid. Plausibly, yes, but that is not proven. And those drugs are not yet at a stage where they can be used at scale. Now, there may come a point in the future that is the case, but right now that is not the case at all. So you may say, right, fair enough, Terry, not drugs, but what about all the lifestyle stuff? If you found out you were high risk for this, surely you'd start to make lifestyle changes. Well, would I? I mean, in my clinical practice, I diagnose people with lung cancer. They don't stop smoking. I see people who lose a limb because of vascular disease. They don't stop smoking. They're not idiots. They know the risk. But actually, knowing risk and fear aren't good ways to affect behavioural change. And so I'm just not convinced that knowing about genetic risk actually would lead me to change my lifestyle. And, I won't share with you all of the different unhealthy lifestyle habits I have, but would the genetic risk stop them? No, they might actually make them worse, because I'd start to feel nihilistic about things. The only thing I might change is it might encourage me to make sure that I had things like power of attorney in place. But actually, we should be doing that anyway. And folks, if you're listening, make sure you have power of attorney in place for your parents, because you never know what's going to happen. If I think about the modifiable risk factors in the Lancet Commission, most of them are things that we should be doing anyway. And you don't need to know your genetic risk to know that you shouldn't be smoking and you should get some more exercise. And actually, maybe if we're going to do something for people aged over 40, we should just check their blood pressure, because that would tell you probably as much about your future dementia risk, and it's something you can actually do something about. I want to finish just by thinking about screening. So if we're going to make this thing available, effectively what we're going to have, whether we like it or not, is we're going to have population screening. Now, the UK Screening Committee have criteria for when you should introduce screening. And if we think about what those criteria are, I don't think we're in a stage that they're met. So the criteria are that the condition has to be important. No doubt the condition's important. We need to know that all available prevention strategies are already being done. That's not the case. We need to understand the natural history, and we need to understand what the natural history of a disclosure of genetic status is. And at the moment, we don't know that. There needs to be an effective treatment, and again, we don't have that right now. There needs to be research to show that disclosure of this genetic status leads to a benefit. Not done. And there has to be the infrastructure to deliver this genetic disclosure in a way that's safe for people. And again, we just don't have that infrastructure at the moment. So my argument, Oscar and Adam, is I don't think we're ready yet to make genetic risk available to people aged over 40. Thank you.
Very much. Very eloquent on both sides of the debate there. I'm going to go now. We're going to enter our rebuttal and exchange period, although I feel Terry already addressed quite for the points, many of the points Oscar made. But we'll give Oscar a chance, first of all, to come back on Terry's points. Oscar.
Thank you very much. And I have to say, that was beautifully done from Terry, because I'm actually doubting myself as well. And I think that's an important conversation to have, you know. I will share something personal as well, because when you were talking about what happens next when you have information about your risk of having dementia, or at least what your genes can inform, which is not as much as we would like to. I was thinking that there is a counterpart to the knowledge is power saying, which is that ignorance is bliss, you know. And this has been something, an issue for me as well for a long time, because my dad died of early onset ALS. So genetic testing has been always somehow haunting me. And I think at this point in life, I'm also over 40. The only reason why I haven't got a genetic test is because my wife doesn't want to know. And because precisely what you said, you can, unknow what you already know. So there's no chance for me, because if I know, I couldn't, hold that information from her, and that's it. So I'm not getting that, because we already had that conversation. And I think that's a super important issue, because all this thing coming back to the autonomy of the patients, it's a conversation patients needs to have. It's a conversation that citizens needs to have, and we can't have that conversation for them. And I think this conversation becomes available as a possibility and becomes, meaningful only if there is an offer to make, if there is something available to look up at what is the best information, the best evidence you can with. And it's true what you say about, life being more than genes, and this could be particularly important when it comes to the relatively low power or predictive power of polygenic risk scores. And I think that is something that could be precisely fixed when you involve big numbers, more citizens. I think this is also in a way a question of open science and citizen science, and that, also fits with the idea that dementia is so diverse. Even, Alzheimer's disease on its own is too diverse, that now I think I'm convinced there is no way we come up with something as a proper account of natural history of the disease or a causal proof for treatment, if we don't increase numbers and are able to stratify, really look at the different populations. So we need to involve citizens into this. It's something the scientific system on its own can't really afford. We don't have the tools to do it on its own, and we need the citizens. And then this is which I think is no, and I appreciate your comments on the criteria for screening, because I think making a screening of this would be a wrong, public health decision. But offering a research-enabled risk stratification device would be a super interesting way of cooperating with citizens in a task that requires maybe involving the whole society. And that's why, mission economy and mission vocabulary, I think, resonates with this.
Thank you, Oscar. Terry, would you like to come back on Oscar's points? Although I feel like Oscar has agreed with many of your points. Would you like to come back on those?
Yeah. So, I mean, we're having a debate, and a debate's fun. But I mean, the truth is there isn't a right or a wrong answer. It's about personal autonomy, exactly as Oscar said, and it's about making the decision that's right for you. My fear is that decision for people may not be sufficiently informed unless we have debates like this, and unless people really start to understand the accuracy of these tests right now and what some of the implications are. Oscar, you spoke about the societal benefit and the community benefit. And another argument I want to make is I'm saying I don't think we're ready for this now. That's not to say we're never going to be ready for it. As our understanding of dementia changes, as treatments become more effective, I think there will come a point where it makes absolute sense to get the genetic testing. I'm just not sure that it's now. And thinking about society and community, I'm thinking about the opportunity cost. And that's not just the cost of the genetic test itself, although if you're going to do polygenic risk scoring, that actually does come with financial cost. It's more the cost of getting the test, disclosing that result in a safe way, supporting the person with that information, all of which needs infrastructure that we just don't have at the moment. Another point you made, Oscar, that really resonated with me was the research potential. If we start to generate at scale lots of genetic data, it will improve our understanding, and there is no doubt about that. And something I would never want to be is the person that stands in the way of scientific progress. But this is high stakes information, and it's not like some of the things that we do in research. And because of that high stakes information, I think we do just need to be slightly cautious in how we use the testing. And actually, for me, what we need more research. We need more research into the benefits of polygenic risk scores in clinical practice. And we need research into how you relay that information in a way that is psychologically safe for the person. So I think we're probably coming to the same place, Oscar and I. There are definite benefits, and we're autonomous human beings. We need to make decisions that are right for us. I'm concerned that people might rush into this without all of the knowledge that they need, and they may then get a result and they're left stranded with a result that's psychologically quite difficult for them.
Thank you very much, Terry. Okay, so we've heard from Terry and Oscar making the two sides of the argument. They've come back on each other's points. I'm going to ask a few questions now just to tease something out, and then in about 10 minutes time we'll get round to your questions as well. So do post your questions. We've got quite a few comments in there which we will read out as well, but I'm really interested in your questions to tease out this discussion. I don't know who I'm going to put this point to. So we've if I'm right in understanding you, Terry, you you accept that genetic testings for things like BRCA2 mutations and things have been massively impactful in things like ovarian and cancer, breast cancer, where there are treatments. Are you suggesting that down the line, when those treatments are available, you believe that that's the case? You just don't think the treatments are there yet to support genetic testing?
Yeah, I think that's exactly the case. So for disease-modifying drugs, you need to know genetic status, because genetic status is correlated with harm. And we know people with a certain ApoE genotype maybe shouldn't get the current monoclonal antibodies. So you need to have that information. There are very vocal proponents and people that are against whether we should be using those drugs right now. But I do believe they're going to get better, and I think we will see them being used in routine clinical practice in the NHS. When we get to that place, I can really see a very plausible argument for genetic testing, but we're not there now.
But you take the rather cynical view that that the modifiable risk factors that we do know of now, which can reduce risk, I guess particularly in places like vascular dementia, that even with that information, people won't use it. And so as a healthcare system, we know best and we shouldn't offer that to people.
I'm not paternalistic, and it's difficult to make a generalisation about a whole population. But what I can say is we shouldn't assume that knowledge of a future risk state is going to lead us to healthy behaviours. And actually, there's a whole psychological literature that shows that in terms of behaviour change, threat isn't a good way to affect behaviour change. If I was writing out blank cheques for research, I would maybe want more research into how can we get people to do all of those things we know are good for our brain health and we just don't do. And I don't think being scared about future risk of Alzheimer's based on a genetic test is a good way to motivate people to do that.
Fair enough. Oscar, how would widespread testing be implemented fairly in the NHS? How would you support people to interpret the results?
That's a very good question, and I think I couldn't possibly have an answer to that, which is a very much of a implementation science question. I'm not an expert in, and actually I think that is probably one of the biggest challenges for something like this: the need of creating a whole structure of data governance, counseling, and being able to responsibly disclose the results to the people, to actually empower people to make better decisions based on better evidence. And actually, I think that is something that is a challenge that is approaching us anyway, because we will need that structures, we will need that governance, we will need that counseling for many other things, for many other conditions, metabolic disease, cardiovascular diseases, cancer. We need that. And if we have opportunities in I think cancer has led the way big time on this. And all the psycho-oncologist work on exactly how to manage expectations, anxieties, and the proper way to deliver a result that can be really life-changing. I think we need that for mental health as well, and we need that for neurology as well. So the opportunity of building up this capacity, I think, is actually a very good reason to go ahead. And on the other side, I would say it's absolutely true that we still have insufficient predictive power of these genetic tools and statistical tools. But I think it would be a mistake to underestimate the effect of having big numbers would mean for this, and the ability to actually accelerate our way into better protective treatments, better candidates for interventions in the late stages of the disease. For that, the disease is so heterogeneous that we need big numbers. And I think, again, cancer is a very interesting example here, because it's as heterogeneous as dementia, I think, so, especially certain types of cancer. And the big difference is the time scale. You have a time scale that is short enough that you can put to test some interventions in a way that you will see the results. That is something you don't have in dementia, and just because of that, you necessarily will need bigger numbers to be able to make proper conclusions.
That's a strong case about having the large numbers. I can understand that. Terry, if people wish to know their risk, should healthcare systems restrict that choice? I'm somebody who I wear a smartwatch and I'll always get the latest one, even though it doesn't do much, but because it has another sensor in it that's going to give me another piece. I have, smart scale, smart watch, smart things. I like collecting data about myself and seeing how that changes over time, which is probably to do with my OCD or my, I've probably got some syndrome for why that is. If I wanted to know, is there any reason why you think I shouldn't be allowed to have that information? And of course, if I could do that, if this was an optional thing, it would potentially support, gathering data if I were to volunteer that. But should people have the choice, do you think?
People should have the choice, and we're all autonomous individuals. It's our genetic data. So we should be the masters of whether we know that or not. The argument, I guess, I'm making is about that being an informed choice. And as you've gathered from what you've heard from Oscar and I, there's a lot of nuance to this, and actually making that informed choice really necessitates some quite complex concepts around Bayesian probability and all of this stuff. And so if people want that information, I think it should be available to them, but it has to be available to them in a way that they're making an informed choice, and then when the genetic information is disclosed, they're supported to make sense of that.
So I suppose that's the key point in the motion, isn't it? Is that the House would make genetic testing for dementia risk available, not mandatory, not routine as part of a normal over 50 testing regime. Although I don't know, because I'm also over 50, but I don't think I've been offered anything. But yes, I take that point. Just to ask you both a question now, of course, blood biomarkers are a huge thing at the moment. I'm sure you're both involved in some way in those. Rather than a genetic test, is an annual amyloid blood biomarker test to look at how your amyloid load changes from being 50 over a more predictive potential than genetics. I'll put that out to both of you.
I think a lot of the arguments still apply around understanding what the natural history is, letting people make an informed choice of that, people understanding that even if they are biomarker positive, that is not synonymous with having the condition. You could have a completely clear score sheet for tau and amyloid, live your life happily, and then develop an alpha-synuclein-driven dementia.
And if you were to throw in there, say, 6 million blood tests, at which you collected annually over the next 5-10 years, would the models of prediction have the power to then start to be useful?
You run into real problems then with false positives and how you deal with that. I mean, one Oscar spoke about oncology, and I think actually we can learn an awful lot from oncology. And you can learn from oncology in the right circumstances where the right treatment is available. Genetic knowledge is incredibly powerful. But what I think we've also learned from oncology is we should never assume things. So you could assume if you're an older guy, you would want blood testing for prostate-specific antigen because it's associated with prostate cancer. But actually research shows that community, like at-scale testing for PSA or on-demand testing for PSA actually causes more harm than good. And we know that just by keeping an open mind and doing research to see what the value is. And I guess if I'm making any argument, as well as the argument around informed choice, it's an argument that actually we need research to let us know how to make the best use of the genetic tools that we have at the moment.
Oscar, do you think we've not talked specifically this evening about underrepresentation in research. But we have done before. We've talked about, underrepresentation of women in trials in certain sex differences and minority ethnic groups. Do you think offering genetic testing in this way has the power to help address some of the inequalities we see in these?
Absolutely. And let me answer your previous question first.
Sorry.
Because it's a very interesting question, because when you look at amyloid, for example, as a blood biomarker, it's powerful in terms of it's more powerful than genetics in terms of the immediate predictive power, but it's not in terms of the, let's say, mechanistic predictive power, like what type of dementia you have and what the potential disease trajectories can be. And I think that is the crucial type of information we need to provide treatments that make sense and really accelerate our way to treating patients differently. This is also because, A-beta and amyloid have provided super interesting tools, not only to understand Alzheimer's disease, but also to treat some or to at least modify the course of the disease. But that's precisely what all the forms, or most of the forms of Alzheimer's disease have in common. And what we need now is to try to focus on the differences, to be able to pull the different profiles of the disease apart. And that's where I think your second question is super important, because one of the barriers for having a proper representation of all the diversity, all the human diversity that is affected by the disease, relies on the numbers. And if you have small scale studies, obviously these underrepresentation will have massive statistical consequences. And only if you have numbers that are big enough, all these populations it's not only that you have enough number of people with that condition that will, or in that group, is also that you will start understanding the differences and similarities of that specific group with the global population that will lead you to better inform interpretations of the data.
Thank you very much. It's about time we went to some of our audience questions and points, because I'm keen to get some of these done. We'll bring up the questions first, and then we'll go to the points. We're going to need to keep our answers fairly succinct. Let me spotlight the first one here. Could there be risks from people finding out they're not ApoE carriers in potentially contributing to them being less engaged in risk factor management? So by telling people that they don't have a genetic risk, that they're going to stop worrying about Alzheimer's when they shouldn't, because of course it might not be based on their genetics. Who'd like to take that one? Oscar, let's put that one to you.
Okay, I think we have to make a decision here. How do we model people behavior in response to this kind of information? Because we either think that information will change the behavior of people towards prevention, or that it will not. So I think it's something we need to put to test and know whether people both negatively and positively engage with prevention more or less, depending on the information they have available.
Terry, did you have anything to add to that?
Yeah, I mean, people are funny. You can't assume what they're going to do. Adam, you were talking about your smartwatch. Some of the first trials of smartwatches found that people actually put on weight and became less healthy because they would set themselves a target of, say, 10,000 steps. They would do their 10,000 steps. Then they'd reward themselves with an eclair or, a sausage roll from Greg's. So we really need to be careful about assuming.
You've got a camera in my house.
We need to be careful about assuming how behaviours will change in response to knowledge.
I understand that. Okay, let's take our next question. Because dementia is such a vast condition, it affects everybody in a slightly different way. Is there a point in offering tests, as it could be too vague and generalised to be beneficial to an individual? Terry, why don't you take that one?
Yeah, I think that's a really good question. And it comes to this tension there is between what we might call precision medicine, that says through omics we can really focus in and understand disease, and the messy reality of older age, where you're often living with multiple long-term conditions that maybe interact with each other, on top of environmental exposures and, you know, an environment around which is also interacting with your health. So I'm not a Luddite, and I can see many benefits to precision medicine, but it's not a panacea. And, you know, that question just really makes that point. And, you know, as Oscar said, just as there are lots and lots of flavors of cancer, there are lots of flavors of dementia. And your genetic risk testing for Alzheimer's tells you nothing about your risk of vascular dementia, dementia from traumatic brain injury, Lewy body dementia, all of these other things.
Oscar, did you have anything to add?
Yeah, I mean, just that there in that question which is a very good one indeed. I think there's too much at stake for me, you know, because I'm a scientist and I know that reality is complex and messy. But what I think is there will be patterns in data, and the only truth we have, if any, is that those patterns can help us to make sense of reality, as messy as it is.
Thank you. We'll take our next question. Also, once again, back from Amelia. What continuous interventions do you think would need to be put in place should people want to find out their genetic predisposition and then are told that there's a strong likelihood? So this is a good question about follow-up. So let's say we do offer this as make it available to people routinely. What follow-up do you think, Oscar, given you're arguing in favor of this, I'll come to you. What follow-up do you think people need to have afterwards? This is, or you know, this isn't going to be a one-off exercise. At 50, you say you're an ApoE carrier. What then?
Yeah, I think. Well, it is a very interesting question, because that's the whole point here is what we do with this information. And I think when we say that knowledge is power, you know, knowing on its own triggers questions and conversations about it, and maybe no immediate behavioral change or anything, but conversations that you need to have in the face of the reality of some risk factors operating on you. And I think at the public health level, I think we need to, precisely because this is an opportunity for making contact with specific populations that may be potentially at risk, we may design interventions that are focused on behavioral change, and not just assuming that behavioral change will follow the delivery of the information, but precisely using that information to focus campaigns on people, on whatever the things we already know that could be risk mitigators.
Yeah, I suppose it's actually the people who are going to potentially benefit from genetic testing the most are the people who are positive, because they'll know they can put those things in place. Terry, did you have anything to add? We're getting really tight on time now. I'm very conscious if I'm going to give you a chance to have your closing statements.
So, I mean, just dead quickly, I'm going to answer the way all academics would answer, to say, I think we need more research to find out, you know, exactly how to disclose that and what follow-up is needed. And that's also true for some of the biomarkers. You know, finding out that you, at the moment, have high amyloid plaques in your brain or things like that, you know, we need research to find out, you know, the best way to convey that information and the kind of follow-up that's needed. And that's research that I think is needed right now, because the genie's out the bottle. You know, actually, if you want it commercially, you can get your ApoE status. You know, so we really need to start thinking about how we help people make sense of that.
I agree. Okay, I'm going to whip through these last ones. There are a couple of longer points which might have some questions in there, but I am keen to make sure that we spotlight all the comments that came in. So Amelia said, is there a third option where the patient could be tested but not personally receive their outcome, so they stay unaware but can benefit from the knowledge that they've donated data? I guess that's a bit like the biobank. I mean, you know, do we basically need to expand the biobank and, you know, bring more people in, get more test results? The next point we had was here. Hold on, I need to stop that one first. Knowledge is power. That's true. However, not everyone can deal with that power, and could it be psychologically damaging? I think both of our speakers agree with that one. Seb Walsh makes the point that the majority of high genetic risk will not develop Alzheimer's disease in their lifetime, We have no evidence that disclosing genetic status helps people in their lifestyles. They have no medical therapies to offer. So a good argument for more research needed. Got that one. And goes on to make a second point as well. There's a massive opportunity cost here. We do a lot more good if we spend the money on reducing poverty, improving services, or giving, as you said, you made the point of blood pressure testing. Okay. Great debate. I completely agree, Amir. Thank you for making that point. So since most dementia isn't strictly hereditary, genetic testing gives risk rather than answers. It makes me wonder how will that help people and clinicians interpret that risk? I've been working on a neuroscience-based decision support tool that reduces diagnostic bias by guiding clinicians through structured reflection and interpretation. I'm wondering if a similar guide framework could be paired with genetic testing results instead of creating anxiety or fatalism. The information could lead to clear prevention steps and more supportive care plan. I think we'd all agree that will be useful. Here, Amir, we have a final. I'm going to spotlight this one. First, I want to say how inspiring this event is. Thank you very much, Magdalena. I voted undecided. I find myself inspired but still in doubt. The discussion makes me think about probably one of my favorite social psychological experiments that I want to ask whether you think it applies here. The experiments from the 1980s, asking prostitutes in Kenya, many of whom had unprotected sex, what the chances were of you developing HIV. The vast majority answered highly unlikely. When asked what are the chances of your colleague developing HIV, the majority answered highly likely. Do you think this applies here, and what do you think are the implications for this bias? Any of you want to take that?
I mean, one generalization that I might make is I think people's opinion on this does vary a little bit with their age and how close they're starting to get to actually being at risk of the biology of dementia. And in my 20s, I thought I was absolutely invincible. And I would have said, you bring on all the knowledge, it doesn't matter to me. And I'm now maybe a little bit more circumspect about these things.
Okay, I'm going to, while I get through these last 2 points, I'm going to open up voting on the closing poll. So in the chat now, you will find a link for you to close voting. There are a couple of final points which I will very briefly spotlight. Could this heightened sense of dementia be viewed as a genetic flaw, or could it reinforce the sense of people with dementia being overlooked or excluded from progress in dementia care? I think you kind of both talked to that a little. And then there was another comment here, which I don't think we've spotlighted yet, which was the list of modifiable risk factors. For some reason it's not coming up. Sorry, Diana. The risk of modifiable risk factors for dementia includes many things that are just basic aspects of health and lifestyle everyone ideally should be doing, regardless of the genetic probability of dementia. Knowing you have low genetic risk of dementia can create a false sense of safety, which we did raise. Thank you very much for brilliant audience questions. I'm going to give you both just a minute to wrap up on your closing statements. Oscar, would you like to go first?
Okay, here I go. I want to thank Terry and you, Adam, for this fantastic debate. I think has been, a very nice time. I think with the success of medicine developing treatments for many diseases, we are being left with the ones that are more heterogeneous and tricky, and dementia being a particularly prevalent one. So I think there is a good case for moving towards precision medicine, as Terry was saying. And empowering people to make evidence-informed behavioral decisions. And in that case, the better the evidence, the stronger the decision. I think second, big numbers on genetic data means more predictive power, stronger clinical research. So limitations of the current situation can be eventually corrected by this initiative. That's the mission. And I think the mission is beyond that, is as genetic testing as part of an important push for knowledge-intensive economy, the opening of necessary conversations, as we said, and stronger governance structures. We need to build that, and we can't avoid that for longer. Just to finalize, I would say that there is a very human thing on wanting to know And it comes to my mind this site of, it may be a very nerdy citation, from Carolus Linnaeus, the System Naturae. In the page of the human, like of all species, the human page said, Homo nocet ipsum, so man, know yourself. So there is something very human on knowing, what you have, what are you made of.
Thank you very much. Terry?
Yeah, I mean, you've heard very convincing arguments from Oscar. And I guess debates tend to be black and white, but actually, if I can make a political point, I think we don't have to be polarized on this. It is actually okay to have two views that are slightly conflicting. And I think that's where I am. I see the power of this, but I also see the potential limitations and dangers of it as well. So I guess just to slightly disagree with the argument I was making, I think there could be a role for it, but we really need to make sure that we're offering these tests in a way that supports people and makes them really benefit from the knowledge and doesn't just leave them out in the cold with something that could be psychologically quite dangerous for them.
Thank you very much. Okay, so you've heard both sides of the debate. Should we be offering routine genetic testing to everybody over the 40? What I want to do is just to remind you now that we'd love to get your votes. I'm going to show you or remind you briefly at the start of the debate. We had 68% in favour, 21% against, and 11% undecided. I'm going to share my screen now. We've got a lot of votes in from people. I'm going to share my screen so we can see what the closing votes are. And it's far less cut and dried this time around. So at the end of the debate, 40% of you agree, 40% are undecided, and 20% disagree. So Terry, I think you've done an amazing job of changing people's putting questions, questioning their certainty that this is definitely beneficial and that there's more to talk about here. So there is no clear winner this evening. In fact, we have 40% in favour, 40% undecided, and 20% against. So a kind of smaller number. I mean, fewer people have voted in the closing vote, but a smaller number definitely against it. But you've created a good deal of uncertainty and persuaded people to think a little bit more deeply about this, Terry. So you should be commended for that. Thank you very much to both my brilliant speakers. I think the points you've heard tonight have been really well made, that this would be great because we get lots of extra data that could be used in research and help us in the future. Nobody was particularly against offering this to people if they wanted it. However, that there needed to be a great deal more thought put into how people were going to be supported both in the short and long term and how they were going to act on that data. We also shouldn't assume that just because people had this data, that they would do something with it that was going to be helpful. But however, everybody could see a future where this would be particularly helpful, particularly if, we were in Huntington's disease or a disease where there are, genetic therapies potentially available down the line, that then, of course, having this information to hand would be incredibly valuable. Thank you very much to the incredible Dr. Oscar Lazo, the unstoppable Professor Terry Quinn. I'm Adam Smith, and we will be back next week, where the debate motion is the House believes that prevention should receive more research funding than cure in dementia, with Sarah Page from Manchester Met arguing in favour of the motion and Lewis Todger from UCL arguing against that motion. So I hope you've enjoyed this evening's debate. It certainly helped raise questions for me. I'm undecided on both of these points, and I hope you'll see us next week in the Dementia Researcher Salon for next week's debate. Thank you very much, everybody. Thank you, Terry. Thank you, Oscar. Have a good evening.
Thanks, everyone.
Thank you.